Thank you.
Taking this initiative. We healthcare professional, although we teach patients everything, but we ignore our own home, which is hostel or where we are studying. So good job.
Thank you, sir. Any difference between male and female? No, sir. It was the data was
Status of the students. What are the reproductive status and any relation between this? Reproductive status of all students you examined. Did you record their vision or reproductive status?
yes.
Percentage of students were having reproductive error also. So refractive error, whether they were how many percentage of students had refractive errors?
Around 73 to 73.
You have not mentioned here.
I have mentioned.
You have mentioned.
Only lighting in hostels, but you have not mentioned the crowding in hostels. You have not mentioned that how many students are staying in a room.
Yes, sir. Sorry.
That does crowding has any effect?
Everyone, and my regards to my teacher and judges. I'm here to present the publication trend of endophthalmitis over the past 5 decades in India. If we look at the retinal publications of past 30 years in PubMed, we see that diabetic retinopathy is the most common publication, followed by age-related macular degeneration. But endophthalmitis, which is even more vision-threatening than diabetic retinopathy and AMD, comes close third after DR and AMD. If we go to the worldwide trend, North America and Asia top the list. But when we come to the Asian publications, we can see traces of Dixit Bharat in endophthalmitis publication. We overtake China in this regard. But what about the publication within India? To find the publication trend, we did a rigorous search.
And if you are asking about whether this will stay, I think as long as marriages stay, divorce will also stay. So unless we build data region specific, we cannot design a particular regimen for the management. So recently we found that some of the antibiotics which are recommended globally as empirical antibiotics, they tend to be resistant in India, just like cefuroxime. So we had to look at our own against the cephalosporins. So this way, I think every corner of India has to come up with their own data so that we can design a better strategy for this blinding disease.
These are my co-authors. I will be presenting about intraocular pressure alterations in patients undergoing pars plana vitrectomy. Pars plana vitrectomy is a widely performed vitreoretinal surgery for a range of posterior segment disorders. Advances in surgical tools and tamponade agents have significantly improved anatomical and functional outcomes. Postoperative intraocular pressure elevation remains a key prognostic limitation to pars plana vitrectomy. Rationale to my study is, although pars plana vitrectomy is effective for managing vitreoretinal diseases, aim is to evaluate the intraocular pressure changes before and after pars plana vitrectomy for various posterior segment disorders. Study design is a prospective observational study of 10 eyes undergoing pars plana vitrectomy. Duration is from January 2025 to July 2025. We are excluding any known case of remediation of about 1 hour 30 minutes to 2 hours. IOP was measured using Goldman affiliation tonometry. Timeline which was taken is pre-op, postoperative day 1, postoperative week 1 and postoperative 1 month. Coming to results, IOP was raised compared to the baseline on postoperative day value in most of the cases. This table is showing the mean IOP changes on pre-op, postoperative day 1, postoperative day 7 and postoperative day 30. Here we can see a raised IOP on the postoperative day 1 compared to the pre-op, giving a significant p-value whereas IOP remained elevated at postoperative day 7 compared to baseline, and it normalizes by 1 month. Damage. Take-home message of my study is PPV commonly causes a temporary rise in the IOP, with the highest spike being on the first postoperative day. So early, vigilant and accurate IOP monitoring is essential to prevent the pressure-related optic nerve damage. These are my references. Thank you.
Post-op you measured IOP by applanation or any other method?
Only applanation only. Only applanation only.
Only applanation. And how did you manage the post-op period? If IOP is high?
Ma'am, it was not significantly high. It was from the baseline when we measured it, it was high. So it was not significantly high.
Then why do you suspect?
So because of inflammation, there could be inflammatory modulators going in the macular meshwork and accumulating over there, which
So,
raise the...
because this mild one,
Yes.
the trocar itself causes
Trocar itself
inflammation.
also. PPV also were taken into consideration. So it was not specific to only diabetic retinopathy.
In macular hole you are using oil?
No sir, actually retinal detachment was also...
Okay.
Do you measure the IOP at the time of closure intraoperatively?
Sir, intraoperatively, actually it is already monitored through the machine when the...
So that you can titrate the silicon oil. So, are you aware of any such
after
method?
closure or just before closure, maybe we can check with digital tonometry.
Have you heard about a body you tend to keep it around 20 or less than that?
Yes, sir.
The second question was, were all the cases phakic or pseudo-phakic or was it less than full feed? Silicon oil. Filling of the silicon oil, whether
Full,
it
sir.
was full.
Yes.
How do you decide it's full? Anyway, thank you.
Judges and good morning all. Today I feel honored to show the result of our study with the combination therapy of the eplerenone with the neparfenec in acute CSR. Usually CSR is a localized series detachment of the neurosensory retina in the macular region. It is usually dysfunction of the RP and underlying choroidal vascular abnormalities, which will lead to the accumulation of fluid in the subretinal space. So acute CSR usually resolve itself in 3 to 4 months, but the mineralocorticoid receptors role found out in the pathogenesis of the CSR. So Zhao and Bouchet have done the clinical studies, and they have given the eplerenone for the 5 weeks to the patient. With the combination of the neparfenec and mineralocorticoid in one group, mineralocorticoid antagonist eplerenone, and in one group is neparfenec only. So our main objective was to find out that central macular thickness after 1 month, the visual acuity and subretinal fluid resolution rate. Our study was prospective, comparative and interventional study, and it was done at the Mahanadi Netra Chikitsalaya, Sonpur, Odisha. It was from 1st March to 31st August, and we have included our patients with the age of 20 to 50 years and newly diagnosed case CSR. We didn't take the patient who is a chronic case of CSR and the patient with the impaired renal function, and the sample size is 50, calculated by the priori power.
Was that there was complete vascularization of the retina along with significant regression of AROP at the end of 24th week post-injection in both eyes of each of the 20 babies with no visible adverse effects. And this is the image showing the presence of AROP in both eyes of the patient on the day of ROP screening, and the last picture is showing the regression after 4 months. Now coming to discussion, AROP is a new category initially presented in ICROP3, which has now replaced APROP, because it is now being said that it basically depends upon it inhibits its activity, and biosimilar is a biologic medication having similar efficacy, clinical efficacy as that of the original product, but its cost is low, and this half dose versus 1/4 dose was equally effective. After 6 months of follow-up with complete vascularization post-injection, and the sample size of our study was small, so this needs further studies, and these are some of the studies that have been done earlier. CARE ROP, Rainbow study, these are
So if you make it even further harm, then how could you standardize? There is every possibility that is such a small volume, and in the tuberculosis syringe there is every possibility that the volume may change. You understand what I am asking?
We use a small and sharp needle, that is 30 gauge needle, and this tuberculin syringe, the one we are using is of that nephropride, but there is no final interest in this, but we are choosing that syringe so that there is no dead space and there is less injection reflex.
So my second question is, what biosimilar you told? There are n number of biosimilar. Which biosimilar you use?
Sure, the one which is
or it was different biosimilars across different period of time?
No sir, the one we are getting under government supply, we are using that.
Which company? Is it Sasmita's biosimilar or something or anything?
Sir, I don't
Okay, that's more. There are very limited, or to be specific, one only. Say, Adjumab actually has got the approval. So what biosimilar use, that is very important to know. And my third question is, why you did this even further reduction of the dose? Probably you wanted to study if the half dose is causing some side effect or maybe cognitive defects in these babies or other complications, which we can escape with if we are using a small dose with the same efficacy, with the safety profile. So do you?
So I think we should extend the study so that we can see the long-term efficacy, and we can also see whether there is any unfavorable outcome that is arising after years, and we are selecting this 1/4 dose so that we are trying if we can use the same bottle for many patients.
Cost effectiveness. There was a correct grading of the different stages of ROP.
Yes sir, we had done the photo documentation using that red cam attached to the monitor.
Efficacy even further lower concentration, then we have to be extremely careful to include the similar disease in both the.
The baby is born with no disease at birth. How and when it develops to retinopathy of prematurity with serial fundus examination. So this study was conducted at L. Prasad Eye Institute, Mithu Tulsi Chandrai campus, Bhubaneswar, which is linked to 35 NICUs in 15 districts in and around Odisha. So talking about process in brief, the babies at risk of ROP were identified, and with proper parental consent and counseling, retinal images was taken with the help of 3 Netra Neo instrument, and the first examination was done on any day within 1 to 2 weeks of birth, weekly till the development of ROP or till zone 2.
In the female, showing the vitreous surface is normal, the foveal contour is intact, and there is the inner retinal layer and outer retinal layer are normal, and there is atrophy of the macular area, showing atrophy of outer retinal layer along with RPE layer in the macular area.
It is fine. Once you are coming into the RPE layers and the ISOS junction areas of the ellipsoid layer, you find there is a discontinuity and dipping of the inner retina in towards the RPE Bruch's membrane complex. This dipping actually, some people describe this as subsidence. And most important, if you have a thinning of the central one, you must find a defect underneath the RPE layer.
The shadowing.
Yeah. Are you seeing that?
Shadowing is seen due to the accumulation of lipofuscin in the RPE.
Whenever there is a thinning of the RPE, the transmission of this after
usually seen in, because you just remember these things, shadowing usually in the hard exudate, when it is abstract. So it will, in this case, why the shadowing will be there? Sir? So because
See, when you are doing the ultrasound now becomes easier to travel through a thinned RPE, correct? So then you tend to get a prominence of the area just under that portion, more prominently seen in the choriopocular region. So that's what we look at.
Good morning everyone. Today I am going to present a paper on structural and functional correlation in retinal vein occlusion, a cross-sectional study. So retinal vein occlusion is the second most common retinal vascular cause of vision loss, secondary to after diabetic retinopathy. It is of two types, CRVO and BRVO. CRVO accounts for 1/3 cases, BRVO 2/3 cases. Prevalence is 0.6 to 1.1%. Risk factors are advanced age, diabetic mellitus, hypertension, glaucoma, and etc. Macular edema is the primary cause of visual impairment. Visual acuity and symptoms depends upon the anatomy, shows greater CMT and worse vision than BRVO. There is a stronger correlation exists between CMT and BCVA, guiding diagnosis and prognosis and treatment planning for retinal vein occlusion. Aim of the study is to assess material methodology. A cross-sectional study was carried out in my department with inclusion criteria of BCVA less than 6/12, untreated patients with retinal vein occlusion showing macular changes, and cooperative patient. Exclusion criteria was macular edema due to causes other than retinal vein worse than 6/12, and also cases which had clinically macular edema was present, and where there was no other cause of macular edema like diabetic.
I didn't see any comparison as per your macular edema thickness and visual acuity on presentation or on recovery. Okay, that you didn't compare, I think, in whole of your studies.
No, it was an observational study. I did not include the intervention part.
No, I am not talking about intervention.
I concluded that in a range that visual acuity ranged from...
And diagnosis, I don't think CRVO, VRVO or any vascular occlusion, diagnosis depends on OCT. Your diagnosis is clinical purely. OCT doesn't help you to diagnose the vascular occlusion.
It helps me quantify.
So when there is a structure and OCT, so you have to describe certain things, how far it is whether there is intraretinal fluid, subretinal fluid, drill, other things are there. So that is lacking actually.
We can cut down writing.
As others pointed out, what structure versus what function were you trying to correlate?
These were there in case of OCT findings, like whether it was of cystoid type or spongy type, whether there was any subretinal fluid was there, and functional when I'm talking that how visual acuity correlates with central macular thickness. Correct. That there was a negative correlation. More the macular edema, poorer will be the visual acuity.
But if you look at your concluding slide, you said OCT as a tool to diagnose macular edema is what you are trying to.
Sir, in some cases, in case of early cases, when there is clinically there is presence of retinal hemorrhage that sometimes marks the macular edema that we cannot see clinically. In that case, OCT acts as a tool for diagnosis.
So how does the conclusion match with your study? Your primary endpoints could be that we can ask for OCT in all cases or whatever it is. So I think you have to relook into. Thank you.
And organ damage. The eye provides a direct non-invasive view of these vascular changes, making hypertensive retinopathy, choroidopathy and optic neuropathy valuable clinical marker of disease severity. The various ocular symptoms noted in hypertensive patients includes blurring of vision, sudden loss of vision, hemorrhages fugax and redness. The objective of my presentation is to study the ocular manifestations, to analyze the incidence and clinical patterns, and to describe the diagnostics and management approaches of systemic hypertension. So it was a prospective observational hospital-based study of 150 cases for over a period of 6 months conducted in our outpatient clinic department. All subjects consented were taken consent. Inclusion criteria included patients above 30 years of age who have been diagnosed with hypertension of more than 130/90 on 2 or more visits. Exclusion criteria included patients less than 30 years associated with diabetes mellitus or who had normal BP and who did not consent for the study. 59. The age group 50 to 60 years had more percentage of patients presenting with systemic hypertension of 30.76% males and females 30.50. The various ocular manifestations were grade 1 hypertensive retinopathy to grade CSR patients showed serious detachment and OCT showed subretinal fluid accumulation. They were advised for BP control and stress reduction. These are the various pictures of grade 1 hypertensive retinopathy, grade 3 hypertensive retinopathy presenting with flame-shaped hemorrhages, cotton wool spots and hard exudates. Grade 4 patients had disc edema. And BRVO, this is a superior, very poor improvement in CRO and NAIO in 0.5 lines. CSR showed best improvement of 4 lines. Conclusion is hypertension is a serious systemic disorder which can damage any organ in human body. Hence, we need to evaluate and manage properly to prevent major vascular events. Thank you.
If you go back on your slides, you showed a picture of grade 1, then you jumped to grade 3. So can you describe what are the different grading systems for hypertensive retinopathy?
Classification and Michael Vaughan classification. So
which one is this?
So this is Keith Wagner classification.
It should be mentioned. And grade 2, how do you describe?
So grade 2 hypertensive retinopathy patients will present with arteriolar attenuation, tortuosity and cotton wool spots. Also there will be deflection of the retinal veins, that is Salus sign.
What do you know about focal generalized?
Generalized grade 2 we have focal
Hypertension and retinal vein occlusion, right? So you mentioned about the treatments. Okay. So what molecule you used here? Because 150 to 160 is maximum cases is there.
Yes, sir.
I think so. Right. 150 to 160. So there is 9. So here you mentioned about the anti-VEGF. So this is question actually.
Sorry,
because
sir.
all the anti-VEGFs. So here actually we have to give steroids.
Summarize just only the risk factors that will lead to ocular.
Ocular manifestations of systemic hypertension.
Yes,
so what are the risk factors which can lead to higher incidence of ocular manifestations?
One is hypertension, which I presented, another diabetes.
Hypertension is the reason for which you are trying to look for ocular manifestations.
Yes.
So what are the risk factors in a hypertensive patient which can lead to ocular manifestations?
Yes, sir. Factors like stress or pregnancy or any other syndromes like Cushing syndrome, they will aggravate too.
All these
Presented with this much BP and then they have been started on antihypertensives.
So on the first visit you saw these BPs.
Yes, sir.
Subsequently with control by medication, did it have any good effect?
Yes, sir. After giving treatment, few improved. Like 1 to 2 lines improvement was noted, and CSR showed the best improvement.
presenting a real-world study of eplerenone on CSC. So, CSC, as we all know, is a retinal disorder characterized by serious detachment of the neurosensory retina. It is due to the choroidal hyperpermeability and impaired RPE compactivity, whereas eplerenone reduces the choroidal thickness and permeability and promotes the SRF resolution. So our study was to evaluate the treatment outcomes in CSC with eplerenone therapy. The study design was retrospective data study. Total we took 233 patients, out of which 69 patients were given eplerenone and 48 patients came for more than 1 month follow-up. We included the patients where the FFA leak was central, diffused and at the QMT, where there was recurrence, where they were previously treated with focal laser but the SRF did not resolve. And we excluded the patient where the SRF resolution was seen on observation, peripheral leak was there in FFA. So the treatment algorithm, and if the leak was central, diffused or as a PMD, we gave them eplerenone and asked them to come for monthly follow-up. So 75% of our patients were male who presented at an average age of 43.6.
So how do you extrapolate the pictures you are showing to the results that you are talking in your conclusion?
Yes, sir. Focus was on chronic, but eventually I had to reduce it. I had to take those patients, I included those patients where the SRF did not resolve after 1 month of observation.
About CNVM in CSCR, and most of them are acute CSCRs. So the question is, how long does it take to actually see a CNVM in an acute CSR patient?
So that will take months and months of observation.
So is that valid in your study?
That's it's a study that it's actually a retrospective study.
Whatever it is, your cohort that you picked up was, as per your pictures, were acute CSCR. I did not see any chronic CSCR. So then the obvious question comes, how do you define an acute CSCR and how do you define a chronic CSCR? How do you do it?
Observation even after 3 to 4 weeks, the SRF is when it's resolving. And chronic CSCR, more than 3 months, when the SRF hasn't resolved, we will consider it chronic.
Positivity, this is used to differentiate between the coccidioidomycosis from rhinosporidiosis. Recurrence is there in 10 to 20% cases, as sometimes there will be endospore spillage during the excision and anatomical difficulties. When it's present in atypical areas, there will be difficulty in incomplete excision. But as post-operative measures, we can use, whether there is risk of recurrence, we can use dapsone. This is our study with atypical rhinosporidiosis. 35 patients were there.
Sit before you are counted for a minute.
Sir, actually, hello. Sir, it was videograph. What we did is we asked the patient to sit and look at the far distance. And under all the conditions, we turned off the fan and everything. And then we noted the complete blinks for 3 minutes.
So this blink rates included complete and incomplete blinks?
Only complete blinks, sir.
So do you do blinks?
Yes, sir.
So that means the tear quality is so good.
Yes, sir. After SICS, tear quality improved. Tear secretion improved basically.
So what is the normal tear quality?
Sir, normal is 3 to 2. Sir, with better visual, after post-op,
If normal is 15.
Yes, sir. With well-corrected visual acuity.
Becoming 11 is okay.
Yes.
2 is little.
Yes.
2 blinks per minute. Maybe difference of 2 blinks.
No, she said 2 complete blinks. She did not say incomplete. The reason why I asked, was she looking or reading, was to differentiate. If somebody is reading, there can be incomplete blinks. If somebody is not reading, the blinks will be more complete.
Macular edema rest. Aim is to compare post-op evaluate SFCT as a non-65 non-diabetics aged from 50 to 70 years. Inclusion criteria was confirmed diabetic and non-diabetic status. Exclusion was extreme accident, corneal opacity and other retinal and macular disorders. Clinical workup done pre-operatively was best corrected visual acuity, slit lamp examination, intraocular pressure measurement, direct mode. It was measured vertically from RP brush membrane to chorioscleral junction using automated caliper at the foveal center. It was done pre-operatively and post-op day 1, week 1, week 4 with repetitive clinical examination and OCT. In this table, we can see comparison between SFCT as compared to the diabetic at every visit beginning from the baseline. All differences are statistically significant, that is p-values less than 0.01, indicating a true and consistent physiological variation.
Damage along with any sort of intraocular inflammation, it may result in vitreous hemorrhage, posterior vitreous detachment, or it may cause bleeding from the rubeosis iritis, choroidal and retinal detachments, or one of the rare ones is the endophthalmitis. Similarly, mine is a prospective observational type of the study over a period of 1 year, where the comprehensive assessment of the patient's history was taken. Following their consent, the baseline IOP visual acuity were recorded. Along with the thorough slit lamp evaluation and dilated fundoscopy, we did a OCT macula to record the central macular thickness, following which the procedure was carried out and the patients were called for follow-up to measure